and dear friends. Today's topic is on shifting paradigm in the management of type 2 diabetes, a focus on the combination of dapagliflozin plus linagliptin. See, the diabetes in India is a very big disease, very big problem. A number of the people in India are having the type 2 diabetes, nearly 10.5 crores, and the prevalence is about 8.3%, and this prevalence and the incidence is increasing day by day in a tsunami proportion. So this is the ICMR India study 2022 saying that only 30 to 35% of the diabetics in India are under control. That means that nearly 64% of the Indian type 2 diabetes, they do not attain the HbA1c target of less than 7%. In the same way, the blood pressure also, nearly 46% of the people are attaching are on the target blood pressure, whereas the nearly 55% of the hypertension population, they are not on target with the blood pressure more than 140/90. And if you see the LDL cholesterol, again the 40% are less than the 100, and nearly the 60% are more than the 100. And nowadays, the target of LDL is less than the 70, maybe 50 or 35 in most of the population. So in that way, I think 90% of our people are having LDL cholesterol more than 50 or the 70. So a lot to be done to improve the diabetes care and also the blood pressure care and also the cholesterol care in our Indian population, to give them a good quality of the life and also to live without any complications. So you all agree with me that diabetes is not a disease, it is a syndrome by itself, because diabetes includes most of the risk factors like heart failure, chronic kidney disease, smoking, sedentary lifestyle, dyslipidemia, hypertension, elderly individuals, depression, sedentary lifestyle. So these are all the different risk factors contributing to the complications of the diabetes, leading to ischemic heart disease or heart failure or the CKD. So it's a triad of type 2 diabetes, CKD and the CVD. The CV mortality increased progressively with the declining GFR. See, the diabetes is a strong risk factor, not only for the cardiovascular diseases, but also the development of the CKD, and all the CKD population, they worsens in the presence of the diabetes. And 40% of the patients with the diabetes, upon screening, have the evidence of the CKD. So a lot of the people with the diabetes, on the day of the diagnosis itself, we screen for the urinary albumin creatinine ratio or the microalbuminuria or the creatinine levels. And nearly 40% of the people, they have the elevated albumin levels or the creatinine levels, even at the time of the diagnosis. The risk of the death is over 10 times higher than the risk of the progression to the ESRD for the CKD stage 3. So CKD stage 3 means the GFR between 30 to 60. And most of the people with stage 3, they die before they reach the ESRD for the dialysis therapy or the renal transplantation. So most of the CKD population, even the stage 3, they die because of the cardiac problems. So lot of the kidney patients, CKD patients, they die in the hands of the cardiologist rather than the nephrologist. And if you see the guideline recommendation, the treatment of the hyperglycemia in adults with the type 2 diabetes, the first line therapy is always your lifestyle measures, your dietary approach, your good exercise program, and also cessation of the smoking, moderation of the alcohol, more fiber, less saturated fats, etc. Plus metformin, if it is not contraindicated in most of the individuals. And nowadays, the management of the diabetes is mostly the patient centric or the complication centric rather than the glucose centric. So whenever you see a case of the diabetes, you assess whether this patient is at high risk of getting the atherosclerotic cardiovascular disease, or having the more risk factors, or is the fellow is at high risk of getting the heart failure, or is at the risk of the CKD, or to minimize the hypoglycemia, or to minimize the weight gain, etc. Suppose if the patient is at risk of atherosclerotic cardiovascular disease, the two drugs are very important with the proven CVD benefits. They are GLP-1 receptor agonists and SGLT2 inhibitors. if you start with a single drug and if the fellow's HbA1c is above your target of 6.5 to 7, you can add the other drug. For example, if you are starting the GLP-1 receptor agonist with the individual with the high atherosclerotic cardiovascular risk and obese, and if the HbA1c is at a higher level, you can add the SGLT inhibitor along with the GLP-1 receptor agonist. And if the still the HbA1c is above the target, then you can add the other drugs. At the same time, if the fellow is at risk of heart failure, SGLT inhibitor is the initial drug of the choice. And if the fellow is at the risk of the CKD, again, SGLT inhibitor is a drug of the choice to start it. And if the fellow is at getting the hypoglycemia, to minimize the hypoglycemia risk, so you can start with the metformin, or you can add the SGLT inhibitors or the gliptins. Or if you want to lose the weight, and definitely SGLT inhibitors are the preferable drugs to be started along with the GLP-1 receptor agonists. So the management of the diabetes nowadays is mostly a complication centric. So there is a paradigm shift in the management of the type 2 diabetes. So earlier it is glucose centric. So it reduce the blood sugars, reduce the fasting blood sugar, reduce the postprandial blood sugar, reduce HbA1c. But now it is a person centric and concentrate on the individual as a whole, on the heart, on the kidneys, and etc. See the kidney-heart connection for the organ protection with the SGLT2 inhibitors. See in the heart, you will have the LV wall stress, oxygen delivery, so beta hydroxybutyrate oxidation, oxidative stress. So all has to be reduced to avoid the complications. In the same way, the blood pressure has to be reduced, and there should be reduced insulin resistance, and the reduced plasma volume, reduced sympathetic nerves activity, and more erythropoietin activity, less glycemia. So these are all very, very important along with the diuresis and the natriuresis. So that is how the heart and the kidneys go hand in hand to make the fellow with a good quality of the life. Otherwise, these people will have a lot of the symptoms of the signs. Combined approach with the combination of these HL inhibitors and DB4 inhibitors because they target the several pathophysiological pathways. You know the omnious octet. So they tackle, when you use the HL inhibitors, they tackle the kidney aspect. And when you are using the DB4 inhibitors, they tackle the 5 of the 8 omnious octet. And there will be the improvement of the glycemia and the adiposity, reduction of the metabolic and the vascular risk, because they are more of cardiac benefit, more of the vascular benefit, more of the renal benefit. So obviously there will be the more of the reduction of the complications, and it is a very safe drugs. The simplicity for the sustainable compliance, because now the combination of the SGLT inhibitor and the DB4 inhibitors are available for a better compliance. So extremely relevant to the Asian Indian patient population living with the type 2 diabetes, because our Indians diabetics, they are at high risk of having the cardiac problems and the renal problems. So when you combine these SGLT inhibitors and the DB4 inhibitors, and definitely you can reduce the complications. So addressing the unmet need with the combination of this Dapa and the Lina, as I told you that there is a complementary mechanism of the fixed drug combinations. And when you are using the SGLT inhibitors, these drugs act exclusively on the kidneys. So every day the kidney, the glucose will be filtered through the glomerulus, and all the glucose, filtered glucose will be reabsorbed to the possible communication tubule. When you are using the SGLT inhibitors, you are preventing the reabsorption of the filtered glucose. So whatever the filtered glucose is there, that is not being reabsorbed again into the circulation. So it will go into the urethra, and finally they cause the glucosuria. So when you are using the SGLT inhibitors, the people will pass a lot of the glucose in the urine. So that is a therapeutic glucosuria will be seen there, and that reduces the glucose toxicity. And along with the glucose, water reduction is also will be there. So they reduce the body weight, and they also reduce the blood pressures. And SGLT inhibitors also have an indirect pancreatic effects by improving the beta cell sensitivity. And coming to the DB4 inhibitors, they act in the different ways because they improve the GLP-1. They make the GLP-1, endogenous GLP-1 to act much better, so that they have effects on the pancreas in both ways. So they act on the beta cells to release more and more insulin, and also they act on the alpha cells not to increase the secretion of the glucagon. In the same way, in the intestines, they act in the two ways. One is the glucose absorption from the intestines, and also the incretin effect, that is the GLP-1 and GIP secretions will be at a higher level. They also will reduce the hyperglycemia, and along with this hyperglycemia reduction, they also have the pleiotropic effects. So the fixed drug combination complement each other and targets at least 6 of the 8 components of the OBS uptake. Dapagliflozin as initial combination therapy with metformin in the treatment-naive patients. See, if you see here, the patients presenting with HbA1c more than the 9%, treatment guidelines recommend the combination therapy to achieve the individualized glycemic targets. So nowadays, when the HbA1c is beyond the 9, we always use the combination therapy. Even at the 7.5 also we use the 2 drugs. And when it is more than the 9, so definitely you need the 2 drugs or the 3 drugs to control the blood sugars very effectively to reach the HbA1c target of 6.5. So if you use the Dapa with the metformin, there will be the reduction of the HbA1c by 2%, and metformin alone 1.35, dapagliflozin alone 1.19. So always a combination of these drugs will definitely help the patient in further reduction of the HbA1c. Dapa as an add-on therapy, the constant reductions in HbA1c across a broad range of the commonly prescribed treatments. If you see the monotherapy with the dapagliflozin, and dapagliflozin can be combined with the metformin, dapagliflozin can be combined with the sulfonylureas, it can be combined with the DP4 inhibitor, the gliptins, and it can be also used along with the insulin. So the dapagliflozin is a very good molecule to be used with all other classes of your OHs and also to the insulin for the good reduction of the HbA1c. See, the Dapa delivers an additional benefit of the weight loss across a broad range of the treatments. So even with the monotherapy or with the metformin therapy or with the sulfonylurea therapy or with the gliptins, so they reduces the body weight much better when compared to the individual drugs. See, the Dapa add-on therapy versus the insulin dose. So when we are using along with the insulin, the 50% greater reduction in the HbA1c with the Dapa will be seen, and as an adjuvant to the insulin therapy, Dapa therapy significantly improved the glycemic control with the clinical advantage of the weight loss, insulin sparing, and the less hypoglycemia. There will be a significant systolic blood pressure reduction at the week 12. If you see here, the systolic blood pressure with the dapagliflozin and the dapagliflozin, see here with the ACE and ARBs, dapagliflozin, the systolic blood pressure reduction is about the 10.4 millimeters of the mercury. And when the fellows, when they are taking the 2 drugs, that is ACE inhibitors plus ARB plus another antihypertensive drug, preferably a calcium channel blocker and a diuretic, and the Dapa, by adding the Dapa, there will be the further reduction of the blood pressure by 11.9 millimeters. Most of the OHs, they cause the hypoglycemia, but the low intrinsic propensity to cause hypoglycemia by the dapagliflozin. Because the dapagliflozin is not an hypoglycemic agent, it is an anti-hyperglycemic agent. This is a very good study, a declared TB58, a Dapa effects on the cardiovascular events, thrombolysis in the myocardial infarction. Here they have studied about the 17,000 patients with type 2 diabetes or established CV disease in about 7,000 population and multiple risk factors in about 10,000 population. So very good number of the type 2 diabetics with an established CV disease about 7,000 and multiple risk factors about 10,000. See, if you see this study, there will be the mean baseline HbA1c reduction, and also the duration of the diabetes is about 11 years, and the GFR is about 5.2 ml per minute per 1.73 square meters of the body surface. If you see the endpoints, both the primary and the secondary endpoints, so there will be the reduction in the cardiovascular diseases, there will be a reduction in the hospitalization for the heart failure, and the major adverse cardiac events also there will be the reduction, and also the renal composite effects are also will be reduced. So the dapagliflozin used in the type 2 diabetes in the high risk individuals with an established cardiovascular disease, there is a big reduction in the heart failure admissions and the major atherosclerotic cardiovascular diseases and also the renal complications. See here the endpoints and the complications. If you see the hospitalization for the heart failure, very much reduced with the dapagliflozin, so that is much better. And whereas the decline in the GFR is also much less with the dapagliflozin. And what about the glycemic efficacy and the cardiovascular risk factors? So HbA1c reduction is good, weight loss is there, the reduction in the systolic blood pressure, reduction in the diastolic blood pressure. So all these are very good as far as the cardiac complications are concerned and also the renal complications are concerned. So the dapagliflozin helps in many ways in these populations. And what about the elderly population? See, the Dapa reduction reduces the composite of the cardiovascular death or hospitalization for the heart failure, and major hypoglycemia is less frequent with the dapagliflozin. See, in elderly population, we should not invite the hypoglycemia. Suppose if they get the hypoglycemia, sometimes no, that could be the neuroglycopenic hypoglycemia without any warning symptoms. They fell on the ground with the convulsions, and also sometimes death also is possible in elderly hypoglycemia. So by using these drugs like the dapagliflozin, the chances of hypoglycemia is very, very high. So the overall efficacy and safety of the dapagliflozin were constant regardless of the age and may be considered a valuable glucose lowering agent even in the elderly population also. So these are the major studies with the SGLT2 inhibitors, empiric outcome with the empagliflozin, canvas that is with the canagliflozin, and declare TB that is with the dapagliflozin. So these three are the three different SGLT2 inhibitors available in the market. Nowadays we are using more of the dapagliflozin, about 90%, and some people are using the empagliflozin. And nowadays we are not using the canagliflozin because of the fear of the peripheral vascular disease or Horner's gangrene or the amputations. And if you see here the declared TB 58, there are about 17,000 patients. Primary prevention cohort is good. Secondary prevention cohort is also good. There are the good number of the women and history of the heart failure in about 10%. The average age is about 63.9 years. This is another study where the Dapa heart failure. So dapagliflozin patients with the heart failure and the reduced ejection fraction. Here there are about 4,744 patients, and this dapagliflozin was used in both diabetics as well as the non-diabetics. So the diabetics are just 45% of these 4,000 odd patients are the diabetics, whereas the 55% are the non-diabetics. See, in both the diabetic and the non-diabetic subgroups, the dapagliflozin fares better. So that is the reason nowadays dapagliflozin is the very favorable drug for all the cardiologists to use it in the heart failure population. So in the heart failure, the four pillars and one pillar is now SGLT2 inhibitors along with your RNI and mineralocorticoid receptor antagonists and vasodilator beta blockers. So these four are the pillars of the management of the heart failure, and one pillar is the SGLT2 inhibitors in diabetes, even in the non-diabetics also. So secondary outcomes, the CV death or the hospitalizations are very much reduced with the dapagliflozin, and the heart failure hospitalizations also reduced with the dapagliflozin, and finally all cause deaths are also reduced with the dapagliflozin arm when compared to the placebo arm. So there is a constant benefit of the dapagliflozin and the clinical outcomes across the spectrum of the BMI. So don't think that Dapa is useful for the obesity because it reduces the blood pressure or reduces the blood weight, etc. But it can be used even in the normal body weight individuals, even in the underweight body weight individuals also. So the mean decrease in the weight at 8 months of the dapagliflozin is nearly 1 kg. So now we discussed about the dapagliflozin usage in the heart failure, usage in the cardiac patients, usage in the heart failure even in the non-diabetic patients. Now let us consider the kidney outcome trials of the dapagliflozin. So this is a good study, the Dapa CKD study. Here they have used the dapagliflozin 10 milligrams once daily versus the placebo, a median study of about 2.4 years to assess whether the treatment with the dapagliflozin compared with the placebo reduced the risk of the renal and the cardiovascular events in people with the CKD with or without the type 2 diabetes. Again here they have taken the non-diabetics also in this study, the Dapa CKD study, to use the dapagliflozin. So it shows very favorable results. So that is the reason nowadays even the nephrologists also they are using the dapagliflozin in all the CKD population with the diabetes and also without the diabetes. So the primary outcomes, the GFR decline more than the 50% and the ESRD or the kidney or the CV deaths reduction is by 40% yearly. So that shows the effects of the dapagliflozin were similar in participants with and without the diabetes also, as far as the positive results are concerned. So Dapa safely reduced the kidney and the cardiovascular events independent of the baseline glycemic status. So in patients with CKD with or without the type 2 diabetes, dapagliflozin compared to the placebo, they reduce the risk of the renal failure, reduce the risk of the death from the CV causes and hospitalization for the heart failure, the prolonged survival. The effect of the DAPA was consistent with the patients with or without the type 2 diabetes. Both are having the good results. The benefits of the DAPA in CKD patients also will be seen. So these are all the benefits of the dapagliflozin as far as the cardiac and renal outcomes are concerned. See, this is I think the best slide of today's talk. Approach for improving the outcomes in patients with the diabetes and CKD. See the lifestyle methods. See, they are very, very important. Healthy diet is important. Physical activity is important. Cessation of the smoking is very important. And if the person is overweight or obese, so definitely the weight reduction is also very important, up to the 10% of the initial body weight. So the regular risk factor reassessment is very needed here. So after that, you have to start the drug therapy. So first line drug therapy, even most of the people with atherosclerotic cardiovascular disease are at risk of heart failure in the CKD, start with SGLT inhibitors. Initiate if the GFR is more than the 20, continue until the dialysis or the transplant. See, SGLT inhibitors are contraindicated when the GFR is less than 25 or the 30. You can remember as the 30. So if the less than the 30, better to not to use the SGLT inhibitors. Metformin is good. Again, that also can be used till the GFR of 30. And RAS inhibitors, your telmisartan, olmesartan, etc. Then the maximum tolerant dose if the person is hypertensive. Because in all the diabetic individuals with hypertension, the first drugs of the choice are either ACE or ARBs, and preferably we use the ARBs. Moderate or the high intensity statin. So statin is a must for all the diabetics and the hypertensives. So irrespective of their lipid profiles. So the lifestyle methods are very important, like diet, activity, cessation of the smoking, weight management, and the first line drugs are the metformin and SGLT inhibitors or RAS inhibitors, and then the statins. And then additional risk benefits. Suppose if the person is obese and affordable, you can go with the GLP-1 receptor agonist. Now the oral GLP-1 receptor agonist is available, oral semaglutide by Ibelsus, or you can use the parenteral GLP-1 receptors once in a week also. And the non-steroidal mineralocorticoid receptor antibodies are available. Finerenone by brand name. Last time we discussed about the finerenone therapy with the ACR more than the 30 milligrams per gram and the normal potassium. So here the potassium levels should be in the normal to use the finerenone. And the finerenone is available in the two dosages, 10 milligrams and the 20 milligrams. When the GFR is less than the 30, you can use with the 10 milligrams. When it is more than the 30, you can use the 20 milligrams. Dihydropyridine calcium channel blockers and other diuretics, they are also very much needed to treat the hypertension individuals. So most of the hypertension in the diabetics, they need 3 or 4 drugs. So the 3 drugs, your telmisartan, your amlodipine, and chlorothalidone or hydrochlorothalidone are the must. And then you can add the bisoprolol, etc. If still the blood pressure is more than 140/90. And the antiplatelet agents are very much needed, your aspirin or the clopidogrel. And then ezetimibe. Suppose if the statins alone, if the LDL is beyond the 70 or the 100, then you can add the ezetimibe, or you can give the bempedoic acid or the fenofibrate when the fellow's triglycerides are more than 350 or the 400 or 500. So that is how we have to add the different drugs to tackle the metabolic lipid disorders. So this is very important to know that. So the lifestyle measures, metformin, SGLT inhibitors, RAS inhibitors, statins, and then the other drugs are also very much needed to treat most of our people to have their heart and kidneys to function very well. This is also another very important slide. Shows you the heart failure benefits of the dapagliflozin are irrespective of the patient, age or the gender. So it acts better in both the males and the females, and also acts better even in the elderly population also. And what about the comorbidities? So dapagliflozin can be used in the diabetics with obesity, or with atrial fibrillation, or with the heart failure, or with the GFR reduction, that is your CKD. So these are more common comorbidities we see in the diabetic individuals. See the disease heart failure. So again, even with the ejection fraction, the low ejection fraction, so the heart failure is now divided into three groups: heart failure with the REF and the PEF and the mid-range ejection fraction. Depending on your EF, that is your ejection fraction, less than the 40 is the REF, more than the 50 is the PEF, and between 40 and the 50 mid-range ejection fraction. And when the anti-proBNP is very much elevated in the presence of the heart failure, even in such situations also you can use the dapagliflozin. So the benefits are many. Heart failure reduction, CVD reduction, and then the asymptomatic, the functional is good. So these are all very, very important aspects. So the patient comorbidity disease are very important. Now, another few minutes we will spend on linagliptin. So far we discussed about the dapagliflozin, that is the SGLT inhibitor. Now move on to the linagliptin, that is the gliptin. See how the different gliptins in our hand. So the first gliptin entered into the market is the sitagliptin. Then the vildagliptin, saxagliptin, linagliptin, and also in India we use a lot of the teneligliptin also because it was cheap and compared to the other gliptins. All the gliptins are costing about 80 or 100 rupees. Teneligliptin is available at 8 rupees or 9 rupees. So a lot of Indians they use the teneligliptin in a big way. But now almost all the gliptins are available at the price of 8 rupees to 10 rupees. Now we have the good choice of using the best gliptins available, useful for our patients. So now coming to the linagliptin. So the linagliptin is primarily excreted via bile and the gut. That is the biggest advantage with the linagliptin. All other gliptins, in the presence of the renal failure, you have to reduce the dosage of these gliptins, except the linagliptin, because the excretion is not through the renal, but excretion through the bile and the gut. So all of the DP4 inhibitors are primarily excreted via the kidneys. All of them have dose adjustments are not recommended for patients with a moderate or a severe renal impairment. And what about the hepatic impairment? See, because India now the people are heavy alcoholics. The most common ultrasound finding nowadays is the fatty liver, and a lot of these fatty livers will convert into the cirrhotics in the next 1 or 2 decades. So hepatic impairment is also very common in our modern India. So the patients with the mild, moderate, and severe hepatic insufficiency, you can use the linagliptin. So no dosage adjustments for linagliptin is necessary for patients with a mild, moderate, or severe hepatic insufficiency. In the same way, no dose adjustments is required for the CKD also. These two are the biggest advantages of the linagliptin. So linagliptin is studied across the patient, all the type 2 diabetes. The newly diagnosed you can use along with the metformin or as a single drug, or uncontrolled on the metformin you can use with the linagliptin combinations, or metformin plus sulfonylurea. Still the blood sugars are very high, you can add the linagliptin. Or if the fellow is already the metformin, sulfonylurea, and the insulin, still the sugars are very high, you can add the linagliptin. Even in the elderly population, even though with the hepatic dysfunction or the renal dysfunction, you can use the linagliptin. So below is all the studies are there. So all the studies show that this is a very good drug to be added for most of our patients. So Lina achieves HbA1c decrease up to 1.2% in type 2 diabetic patients with more than the 9% baseline. So a nearly 1% reduction of the HbA1c is a very good reduction to be seen with these drugs. Lina plus metformin in patients with the newly diagnosed type 2 diabetes and marked hyperglycemia. So straight away you can start with this combination of the metformin and the linagliptin. Once the HbA1c is more than the 7.5 or 8 or the 9, you can use the two drugs. Already I told you the elderly and irrespective of the age and the duration of the diabetes is a very good drug. Significantly lowers the albuminuria also. So this is also renal friendly. On top of the recommended standard treatment for the diabetic nephropathy. See 29% in the albuminuria versus the placebo after 24 weeks of the treatment. So this is a good study, the Carmelina. So this Carmelina study, they studied nearly the 7,000 population. Linagliptin was given about 5 milligrams per day versus the placebo. So they have taken the most of these people, 57% of this group had an established cardiovascular disease and 74% had the prevalent kidney disease. So both the CKD and the CVD is there to about the tune of about 60 to 70% of the population. And already 58% of these people are on insulin and about 55% are on metformin. Then they added the linagliptin. This study shows that the time to the first occurrence of confirmation for the hospitalization for the heart failure is reduced with the linagliptin therapy. In the same way, the death due to the kidney disease is also reduced with the linagliptin therapy. And the first occurrence of albuminuria progression is also reduced with the linagliptin therapy. So the Lina, when you add with the metformin or with the sulfonylureas or the insulin, so definitely reduce the blood sugars and also reduce the albuminuria and also give good protection to the heart and the kidneys. So that is the study of the Carmelina. Now the Carolina study. So in the Carolina study, they studied the advantage of the linagliptin versus the glimepiride. So they studied versus the glimepiride here. The patient with the type 2 diabetes were randomized to die. Here about 6,000 patients. Lina was given in some population about 5 milligrams and glimepiride with 1 to 4 milligrams. So here again, 42% of this group had an established cardiovascular disease. 37% had the more than the 2 CV risk factors, and 40% had the type 2 diabetes for less than the 5 years. And the treatment naive about 9%, on insulin 0, and metformin 83%. So this is how they studied. They have grouped this population, glimepiride versus the linagliptin. So this Carmelina and the Carolina both say that this drug is a long-term effects are very, very good as far as the cardiovascular and the renal protection is concerned. So a robust CVOT program demonstrating the long-term safety of the linagliptin in 2 independent CVOTs for a broad range of type 2 diabetic patients. So the Lina has the broadest clinical evidence. So monotherapy you can use with the linagliptin. A dual therapy you can use along with the metformin. As a triple therapy you can use with the metformin or SGLT inhibitor or the linagliptin. High CV risk individuals it is safe. Heart failure safe. High kidney risk also the same. Whereas in heart failure saxagliptin is contraindicated, but here linagliptin can be safely used with the even in the heart failure also. So Lina can be used with no dose adjustments because the excretion is through the gut and the bile. So in both the hepatic and the renal failure population, you can use it Lina. So this is another Indian data. It is a phase 3 clinical study. They studied the fixed drug combination of the dapagliflozin and the linagliptin. Now you have the on the row D here, a combination of the dapagliflozin and the linagliptin. They studied this a combination of these drugs. So the primary objective is the reduction in HbA1c. The secondary objective reduction in the fasting blood sugar and the postprandial blood sugar. So they fared well in this study in controlling both the fasting, postprandial as well as the HbA1c. So dear seniors and the friends, to be summarized, the type 2 diabetes is a chronic disease. It is not a disease, it's a syndrome. Because we are dealing with type 2 diabetes means you are almost dealing with internal medicine. So because type 2 diabetes complicates with the cardiovascular and the renovascular complications, the treatment approach is shifting from the glucose-centric, earlier reduction of the blood sugars, but now it is a patient-centric and recommended by the international guidelines as well. And the FDC targets the major pathological components of the obvious octane, and the Dapa and the Lina will address not only the glycemia, but also the cardiorenal issues in the type 2 diabetes, which reflects the real clinical practice scenario, because a lot of our people are having the renal and the cardiac problems. So by using this combination, we can tackle that. And this is only once daily regimen. Will eventually improve the compliance also and good quality of the life. So they have the 5 milligrams of the linagliptin and 10 milligrams of the Dapa. So thank you very much for your patient hearing. If you have any doubts, I'm very happy to clarify.